Welcome, everyone, to the next episode of Medicine 3.0 podcast. I'm super excited to be here. My name is Dr. Catherine Isaac. I'm one of the bionic physicians, and I am thrilled to be able to communicate with someone I consider to be a mentor in terms of learning about women's health. Dr. Jane Minkin is a Yale OBGYN and has been working in the field of women's health for a number of years. Not only is she an excellent clinician, but she has dedicated a good portion of her life to teaching other doctors and medical students and residents all about her field, and she really is a gem. And I'm so glad that she is here with us at Medicine 3.0. I'm also excited to tell you that she is one of our advisors for Bionic Health platform, and it's been super helpful to have her insight when we have some interesting cases that come up. So welcome, Dr. Minkin.
Catherine, thank you so much for asking me to be with you and also to be with you on Bionic. And it is a pleasure to be of some assistance here and looking forward to our continued work there. Sure. And you've got great questions for me. I know that. And basically, I'm sort of graphic in my descriptions, and I apologize to anybody I'm grossing out or whatever. But basically, menopause is about the pooping out of ovarian function. Pure and simple is what happens. And the key thing about it is it would be real nice if it were sort of a linear sort of thing, that it went down gradually and stuff like that. But the decline in ovarian function is very raggedy-jaggedy. And so what I draw from my medical students, for example, and they're not even remembering what this is anymore, but I draw a graph that goes down sort of up and down. I mean, it's going down, but it's very jaggedy. And I tell them what it is really the stock market in September of 2008, and that's the Dow Jones Industrial Average. But the key thing is it's going down to be sure, but it is a very jagged road. So sometimes your ovaries will make no estrogen whatsoever that day. And guess what? The next day for, makeup time, sort of, the ovaries will make twice as much. So what are you feeling? Well, one day you may be feeling hot flashes and feeling very uncomfortable that way and not sleeping real well. And then the next day your breasts will be killing you because you're getting this real huge amount of estrogen going up. And so that's not uncommon to hear those kind of complaints. And one of my favorite statements is, as far as taking care of women dealing with menopausal health issues, any idiot can take care of menopause. That's easy. It's perimenopause that's the trick, because it's hard to define, and it's hard to define exactly when these changes are occurring. You can say, well, I started when I was 47 and a half. Well, that's hard to say because it's really retrospective. You can look back and say, oh yeah, but we're not marking our days of how we're feeling. So it's really hard to say exactly when it starts. And as far as doing blood tests, because we like to do blood tests a lot, many endocrinology folks do. And the problem is, when we get a blood test, it may be on a day that your ovaries aren't working at all, or it may be on a day your ovaries are working double time. And, we're not going to get blood tests on you, 20 times to drive you crazy. So it's very hard to tell people what's going on, unfortunately.
Mm-hmm. Yeah, absolutely. I think that was something that was so interesting to me when I started to delve more into understanding the physiology of menopause and perimenopause, is that you were having these periods where you could have super high levels of estrogen in addition to that estrogen deprivation. And I'd love to hear from you also just how you talk to women about the symptoms that they can experience, because it's not only having hot flashes that is representative of these hormonal changes. Can you tell us a little about that?
Sure, and hot flashes are classic. Okay, and we also have to talk about, because this gets to be very confusing, that symptoms are different in different people. Okay, different populations. So, for example, hot flashes are the number one complaint of women in the United States. That's true. Sleep disorders are right up there, and sometimes you can wake up without having a hot flash, and then sometimes the hot flash will wake you up, and then you'll be wide awake. Those sort of things can happen. However, if I were giving this lecture in the Philippines, okay. And I've given a lecture in the Philippines, albeit on Zoom, for some of my friends over there. But the number one complaint there is achiness. And yes, American women can get achiness, to be sure, and some women are really debilitated by it, but it's not our number one complaint in general. And also the length of duration of symptoms in the U.S., that the hot flashes everywhere tend to be one of the early symptoms, not one of the late symptoms. Vaginal dryness, which is classic for menopause, tends to occur late. Now, Can you have vaginal dryness before you even skip one period? Absolutely. It's just that on average, it tends to be later on in the menopausal process. And what's also really interesting, and here I am confusing all of our viewers and listeners right up front, is that different ethnic groups, different racial backgrounds have different symptoms at different times. So, for example, if you look at the overall duration of hot flashes in women in the US, and this is well defined, a really nice study called the SWAN study, which is still going on, which stands for Study of Women's Health Across the Nation. And it started a number of years ago and it's still continuing. It just got renewed, got some money for it to keep it going. But the average duration we know is about 7.4 years of hot flashes. However, that it looks like, at least in the SWAN study and other observational trials, that this is the average overall. Unfortunately, for African American women, the average duration is like 10.4 years, which is a long time. For women of Asian backgrounds, it tends to be 4.5, 4.8 years. Do we know why? No. And one of my standard lines that I tell people is trying to trick my medical students all to go into menopause research, of course, is that there are guaranteed Nobel Prizes for the people who can figure this out. And I always say to them, and your mother wants you to get a Nobel Prize, even if you don't. So anyway, but we don't know the answers to these. My patients say, why? And I'm like, I don't know.
Yeah. So I love the fact that we're talking about this because I think it's so important because many women, as you say, don't necessarily present with the usual typical symptoms of hot flashes. And they may be coming into their physician or their primary provider with some of these atypical symptoms, and it can be quite confusing. So I love that you're mentioning. What other atypical symptoms do you hear about for women going through perimenopause and menopause?
Sure. Well, I don't know if I would say necessarily atypical. Plenty of women get these different symptoms. It's just intensity and stuff can vary from folks to folks. As we mentioned earlier, vaginal dryness certainly is a really common symptom. That in general we think is more related to the absolute value of estrogen floating around rather than the fluctuations up and down. Okay.
Mm.
But along those lines, they can get vaginal dryness, they can get irritations, they can get urinary symptoms, they can start developing urinary tract infections, they can develop incontinence, all these fabulous things along those lines. Again, the sleep we mentioned. Also, women oftentimes complain of decreased libido. Now, is that because it's related to the discomfort? Well, certainly some of it is. And I always say if somebody comes in with decreased libido, let me fix your vagina, please. And we try to work on that. And they're like, that's not it. And I say, well, let me just fix it anyway, because I don't want you to want to have sex if it's going to hurt anyway. That would be silly.
Makes sense.
It's not a good thing. So, and indeed, what's interesting is like I can get somebody a good vagina in about 3 months. It takes sometimes that much, and sometimes my patients will come back in 3 months and say, "Yeah, you were right. It was just the discomfort that was really driving me crazy. And now that I'm comfortable, I want to have sex." Well, that's great. Some people will come back and say, "No, my vagina feels absolutely perfectly, and I still could care less." Okay, that's a different story. So
Right.
those are all possibilities and things going on there. Again, the achiness we talked about. Some people complain of sort of psychological type effects, brain fog, forgetfulness, attention deficit disorder type complaints that we hear. And of course, sleep is a paramount one. And again, trying to dissect out what's the cause, because if somebody has terrible sleep, their brains don't work so good. It's pretty simple to me. So, but is there something else besides the lack of sleep? Yeah, there seems to be something else for many women, this brain fog sort of things that women are experiencing. So it's a whole panoply of things. And it really, and again, what I try to teach, again, going back to my medical students, is I'm assuming that most of them aren't going to go into OBGYN, even though I tell them they all should. But maybe one or two, no, maybe 5 or 10% might. But the rest of these folks are going to go into other specialties, and they'll see a patient coming to them, somebody coming in complaining of severe arthritis, and
Right.
a 50-year-old lady, well, she could be getting arthritis. It doesn't have to be menopause. That's certainly the case. And many of them will never even think about menopause as a possible etiology. And they'll be working the woman up and they'll be getting lupus tests and rheumatoid tests on her. And God bless them, I think that's the right thing to do, because you want to make it a diagnosis of exclusion. You don't want to miss lupus on somebody. But indeed, they'll come into me and they'll say, I've had 10 negative tests for all these different things, and I still can't do anything. I'm still immobile. And, maybe it's menopause, let's think about that. So we have
Absolutely.
to put that in.
Yeah, that's great. And one thing I've heard you talk about, just going back to the genitourinary symptoms of menopause, I think you phrase it as like the bladder shares a wall with the vagina. So it makes sense that there's symptoms that are going to arise in that area as well. Is that right?
Yep, absolutely. And indeed, there are what we call receptors, which are little things that stick out on the cell membrane that the estrogen can attach to. Okay. And in many cases, the estrogen turns on the cell. And so there are estrogen receptors in most cells in the body, to be honest, plenty in the brain, okay, plenty in the skin. And indeed, one of my favorite lines, because there's a lot of brain chemistry going on with the estrogen declining, and we can talk about that as far as exact mechanisms there.
Mm-hmm.
A standard line that I try to get across to my patients, because they're oftentimes not getting any sympathy or feelings for what they're going through. And, their partners sometimes will come in and, the standard, I shouldn't say Archie Bunker, but I'll say Archie Bunker for the older folks who remember that show.
I remember.
It's all in your head, Edith, it's all in your head. And in a very derogatory fashion. And what I try to teach my patients to do is to smile sweetly and say, yes, dear, it is in my head. It's right in my hypothalamus here, which is right behind the bridge of my nose here. And that's where many of these chemical changes are going on, which are reflecting the decrease in estrogen levels. So yeah, it's in your head, but it's not in the derogatory way you think.
Absolutely. Yeah, it's so fascinating and something I want to learn more about. But knowing that you're having changes in estrogen, you're going to be having changes in testosterone levels. I think your DHEA and DHES, which are neurohormones. Can you tell us a little bit more about that?
Sure. I think the testosterone story is very interesting for women. Again, most guys don't like to think they have estrogen either, but trust me, they got plenty of estrogen. We also have testosterone, and our ovaries make testosterone. Now, what's interesting is if you look at the curve of estrogen production, it goes down precipitously. The average age of menopause is 51. People go through menopause at 35 too. There's some unfortunate young women who do that. You can go through menopause at age 60. So my definition of normal is 35 to 60. Whereas the changes, again, are sort of a retrospective diagnosis. And you say, that's what I was feeling 3-4 years ago. I'll bet that was the beginning of perimenopause. And it probably was for them, with some decline in ovarian function. But the ovaries make testosterone also, and the decline is much more gradual. Okay.
Mm.
So although it may start at about 51 an average, it goes on for another 10 years, 12 years, something like that. So even somebody who's 5 or 6 years after their last period, when their ovaries stop making the estrogen, they're still making some degree of testosterone, albeit less than they made 5 or 6 years ago in general. So it's not as precipitous a decline. That's the major one we talk about as well. Some of the ancillary hormones are there as well. And the other thing to remember is, yes, our ovaries make testosterone, but the other source of our testosterone is actually from our adrenal glands as well.
Right. Yes. That's super interesting. And then there's also testosterone. If I remember correctly, the DHEA can get converted to testosterone or it can get converted to estrone. Is that accurate?
Yes, indeed. And there's a lot of interconversion going on. And indeed, that the testosterone levels, for example, if we talk about women, jumping ahead 6 steps here, but for example, women who have breast cancer are often given these drugs called aromatase inhibitors, okay? And even if they're postmenopausal, their ovaries may not be making much testosterone, but their adrenal glands are still making some. And that can get converted into estrogen, and you want to block that process. And that process is referred to as aromatization, the conversion of the testosterone to the estrogenic substances, and you can block that with these chemicals.
Yeah, very interesting. So basically, summary is it's very complex. There are a lot of physiological changes that are happening, and it can be confusing to parse it all out. The next thing to talk about is what are some of the cardiovascular and metabolic changes that we know begin to happen during the menopausal period?
There's significant metabolic changes which are going on. And indeed, as our estrogen levels decline, there's some simple things. Our skin gets dry, our vaginas get dry. That's a simple thing that goes on. As far as cardiovascular stuff that goes on, this is very important because our lipid profiles decline, unfortunately, as far as the goodness of a lipid profile. Our HDL, the good cholesterol, goes down. The bad cholesterol, the LDL, goes up. The triglycerides usually go up in menopause. So all these things are happening. We also, unfortunately, tend to gain a little bit of weight. Okay, now, if somebody comes up to me and says, I hate this menopause, and I was like, well, why do you hate menopause? Let me add to my collection here. And she says, well, I hate the weight gain. And she's gained 40 pounds. It's unlikely that that's related just to menopause. It's probably related to increasing food and activity, things like that. But some of it is related to menopause. And our basal metabolic rates do go down. And people don't like that either. So all these things are going down to try to go against us, and we just have to fight back and stay active and do what we can. And indeed, one of the indications, and we'll probably get into more of this later, and the other thing, of course, is estrogen does have, besides lipid issues, estrogen has effects on our blood vessels. Okay. Estrogen acts in general as a vasodilator. It helps blood vessel walls relax. And when our blood vessels tense up, our blood pressure goes up, so that we tend to get a little bit higher blood pressure because our blood vessels aren't as compliant as they used to be, and some of that is mediated by the fall in estrogen. So indeed, one of the questions that came up, and is it okay for me to bring up the nurses' health study at this point?
Oh, absolutely, yes.
Right. So let's talk about the nurses' health study. And I know I'm going to talk about some science. Don't get scared, folks. Science really isn't bad. It's okay. And the nurses' health study was a study done out of Harvard, an okay study done by Harvard. Imagine me saying that. But it's okay. So anyway, but what was an observational trial. They enrolled 121,000 nurses. And nurses are the most fabulous subjects for a study like this because they're so reliable. They will fill out forms every year. They'll give you blood. They'll give you urine. They'll give you everything. And they're really good people. And you just can follow them. And what they did was just follow these women as they went through the menopause transition, as they were getting older. And certain things happened, certain things didn't. But what they noticed in the WHI study was that, and this was not a prospective randomized thing, it's just observational, that the women who took estrogen, and at that point they were taking estrogen to relieve their hot flashes and night sweats and sleep, things like that, that they noted that the women who took the estrogen seemed to have a significant reduction in cardiovascular disease. And the way I tell when I'm talking to my students about, think about it, think about your family, friends, and think about how many men that have had heart attacks, and most everybody knows a guy that's had a heart attack in the family or friends. And I'll say, were they young guys? Oh yeah, we see some young guys who had heart attacks. How many young women do you see that have heart attacks? And thank goodness it's very rare. And can you see a woman with a heart attack? Sure. Oftentimes you'll see a 60-year-old or a 70-year-old lady with a heart attack. That's pretty common, but she's postmenopausal most likely. Okay. Mm-hmm. It certainly does seem in most people's observations as well that they know women who are older going through having heart attacks, but many fewer women having heart attacks as very young people. And that sort of was one of the things that led to the hypothesis, well, maybe there's something in that estrogen stuff that the women make a lot more of than the guys, that is protecting them. Mm-hmm. And so that led to the question of, is the estrogen that women have protecting them? And then that led to the follow-up question to say, well, if estrogen is protecting against heart disease, maybe we should have women take estrogen to help protect against heart disease. So that actually became the basis from the nurses' health study to do the Women's Health Initiative study, which was indeed a prospective, randomized, double-blind controlled trial where women were given, some were given estrogen, some weren't given. They didn't know what they were getting, and their trajectory as far as their health was followed.
Mm-hmm. Great. Yes. So super important study. I'm glad you're bringing it up. Can you tell us a little bit more about the outcomes? And of course, I'm sure we're going to talk about the controversy around that.
Of course. So anyway, the Women's Health Initiative went on. Big study, NIH study, big deal study. Now, a couple things about the study to understand. That, and I'm getting into some complex stuff. I apologize. So we can talk more about it. So anyway, that if a woman has her uterus in place, okay, and she takes estrogen can stimulate the lining of the uterus to grow, okay? And at times it grows a lot, and at times it can become a uterine cancer. It's rare, but it's not unheard of. And we learned many, many years ago that if we give women progesterone, which is one of the other major female hormones, that progesterone prevents the overgrowth of the lining of the uterus. Pure and simple. That's all there is to it. And indeed, I steal lines from everybody, but I give attribution. So this is from my friend Nanette Santoro, who's the chair in Colorado. She tells her patients, and I think it's a really good analogy, think of your uterus as a lawn. Estrogen's fertilizer, the progesterone's the lawnmower. And it makes perfectly good sense. We're just keeping that lawn, in check there with the progesterone. If you don't have a uterus, you don't have to take any progesterone. You don't need progesterone. It's just there to prevent overgrowth of the lining of the uterus. And if you don't have a uterus, no big deal. That's easy. Okay, so we can do that. So anyway, and people noticed years ago, even in the 60s and 70s, that progesterone might undo some of the goodness that estrogen was doing for the heart. Okay, so when they did this WHI study, they were smart and they said, let's look at women who have a uterus and women who don't have a uterus in two separate groups, because in the ladies who don't have a uterus, we don't have to give them progesterone, and that might have a differential effect on the cardiac, results here. Makes sense. So anyway, so what happens to fast, and the other thing they had with the WHI was a double-blind study, but they did have sort of unblinding officers, and they had people who were, as part of the observational of watching the study, making sure it was all ethical and stuff, a data safety monitoring board. And they were looking for a potential of bad stuff. Most notably, the major thing they were looking for is breast cancer, because obviously the concern is, well, the breast has a lot of estrogen receptors, and, maybe that estrogen helps stimulate the breast and may lead to an increased risk of cancer, So that's one of the major things they were studying. They were also studying osteoporosis, bone loss, because it was well known many years ago that estrogen seemed to help prevent osteoporosis, and they wanted to follow that. Do the women get more? Do they get fewer fractures if they take estrogen or not? So that was another thing that was being observed by the Data Safety Monitoring Board. Okay. Fast forward to 2002. Okay, early in 2002, the Data Safety Monitoring Board says, the estrogen-only group was fine. Nothing funny was going on. Things were going as they expected. But in the estrogen plus progestin group, synthetic progesterones to help protect the lining of the uterus, that group showed a very slight increased risk of breast cancer. Okay, really minuscule. Okay. However, the board said it was statistically significant. You notice the board said it was. I'm not saying it was.
Right.
But anyway, and they said, oops, we better stop the study. Okay. And that occurred on July 9th, 2002, a day that will live in infamy, as I paraphrase something else. And indeed, that women got panicky. The minute they hear something, understandably, that something's going to adversely affect their breast, they're terrified of it. And indeed, another study that I like to show when I'm giving a fancy talk and stuff like that is, what do American women think we die from? Okay.
Mm-hmm.
And there have been a number of studies done. My favorite one was a Gallup organization study. I mean, a poll, and they're pretty good.
Mm-hmm.
And it was financed by the North American Menopause Society at the time. And they surveyed women ages 44 to 65, my ladies. And they said, what is the number one killer of American women? And what percent of American women die from this entity? And indeed, and this study's been repeated numbers of times over the course of time. The first study that was published was back, in 97, I think, 95 was the first NAM-sponsored study. And what they found is that American women believe that 40% of us die from breast cancer.
Wow.
Killer, and 40% of us die from that. Now, I run a cancer clinic. I run a breast cancer clinic. So these are my ladies.
Okay.
It's a terrible disease. But the issue is, it doesn't kill 40% of us. It kills about 4% of us. Heart disease is the thing that kills 40% of us. But American women don't care about their hearts. They care about their breasts. I understand that because of the anxieties out there. So anyway, so what happened is, when they found that there was a very, very, very slight increased risk of breast cancer, they stopped the study. It started going, the journalism went crazy as far as people spreading, this is going to kill you, it's going to give you breast cancer, you're going to die. What's really sad is that the number actually, we look at statistics, and in looking at statistics, it wasn't even statistically significant. That's the problem. And, well, a whole line of the follow-up on the study. But, and the other thing to remember is, the women who had a hysterectomy, who were just taking estrogen, never showed an increased risk. And actually, they showed a decreased risk of breast cancer, which did achieve statistical significance. So that's another story. But anyway, so what happened is, American women promptly went to their toilets and they flushed down every estrogen tablet they had, whether they were estrogen alone or estrogen plus progestin. They didn't care. They were down in the toilet. So anyway, and as of the end of July 2002, there were a lot of ladies who were miserable and having a lot of hot flashes, because we didn't stop hot flashes. We just stopped giving them estrogen. Well, I didn't stop giving them estrogen. They stopped taking it. So anyway, so this is what happened. And basically, estrogen use fell into total decline. Okay, numbers really drastically fell, and women were like, I'm not going to take this stuff. I'm going to die. I don't want to die, that sort of thing. So now, did they go out and exercise because of their hearts? No, they didn't do that, but that's another story. So anyway, so what happened is the study was stopped. And the other thing they didn't note as when they did stop the study, it didn't seem to help prevent heart attacks either, which is they were perplexed by this. Why didn't this happen? Why didn't they see fewer heart attacks? Well, some theories did emerge as far as why that happened. But A, the medicine didn't seem to do what it was purported to do, and B, it was going to give you breast cancer, you were going to die, and that's terrible. Now,
Right.
a couple of years later, they did stop the WHI Part 2, which was the estrogen-only arm, just because they got bored. I mean, there really wasn't any bad data. It was like, okay, we're done. So that study really never showed anything really terrible. Very minuscule increased risk of stroke, maybe not quite achieving statistical significance in some of the parts, but it was reasonably quite safe. So what happened though is, and the sequelae though were tremendous because American women stopped using estrogen, and at the point that was the mainstay of hot flash remedies for people. And so they were just miserable. Other sequelae, what happened is that women were still miserable, and the compounding pharmacies came out and said, hey, we can take care of you. We're going to give you au naturel estrogen and progesterone, and you'll be fine. And what's interesting is they really, I mean, it's the same stuff, basically. It's not anything radically different. But the reason women were convinced it wasn't going to harm them is when you go to the pharmacy, to your Walgreens or CVS or whatever, they have to put in a little package insert about what medicine you're getting.
Mm-hmm.
Pharmacies don't have to have a package insert. So when you went to the compounding pharmacy, you didn't get this piece of paper saying you were going to die. And it was like, okay, I'm not going to die because the package insert isn't there. But it's just they don't have to put in package inserts. That's the major reason they're safer. So anyway, but that's a whole other story. So
Right.
anyway, and then what happened also is with the concomitant women saying, I'm not going to take estrogen anymore. What happened is that medical schools and residency programs just stopped teaching menopause management.
Mm-hmm.
So anybody who graduated from a residency program after 2002 learned no menopause management. And it was like, okay, this isn't so cool. So these people are now the women who are now going through menopause are going to doctors and nurse practitioners who never were taught any menopause. So they're
Mm-hmm.
like, okay, suffer, you'll get over it, you'll be fine.
Right.
And so many women have gone to
Part of
deny it's just done. So that's the problem we're in.
Mm-hmm. Yeah. Yeah, that's so interesting. And I think, I certainly experienced in terms of my training, feeling like I didn't get enough menopause training, didn't see enough cases, not able to really recognize it. And kind of that attitude of women are just going to go through it and it's over and it's just part of what you have to do.
And shut up. That's what the thing was. It's all in your head, right?
And I think, let's talk a little bit about, like you said, the long-term sequelae of the estrogen deprivation from people being afraid to be on treatment, what was happening cardiovascularly, what was happening to their bones without treatment.
Sure. Well, the cardiovascular stuff, again, we've talked about, and there certainly have been, rising rates of cardiovascular disease in women. Now, of course, they're multifactorial there as well.
Mm-hmm.
The bone health issue with estrogen was well known long before the WHI, and that women who were given estrogen had a much lower chance of losing bone, of becoming osteoporotic. And we did see, and we have data from like Kaiser Foundation's Family Foundation, from Kaiser plans where women stopped using their estrogen and significantly increased rates of osteoporosis without women on estrogen. And osteoporosis is a terrible disease. I mean, if you look at the statistics, actually, as many women die from complications of osteoporosis as die from breast cancer.
Wow.
Now, ages are different, to be sure. The osteoporosis women tend to be much older than your women who are, who get osteoporosis are much older than women who get breast cancer in general, not exclusively. But these are problems that we see. And of course, there are other things as far as, I mean, excuse me, I'm being at the hospital here across the street. So prove I'm at the hospital, you hear ambulances in the background. Hi, guys. Take care of those people. So anyway, there are other sequelae, of course, that happen, maybe not as dramatic as fracturing a bone or as dramatic as having a heart attack.
Yeah, yeah, absolutely. I think it's so interesting. Can you also tell, do you have the numbers on kind of what the risk is for women for Alzheimer's risk if you're taking treatment versus not?
The Alzheimer's issue is very, very complicated. Okay. And I'd like to, before we do that, I'd like to segue age at menopause as something
Please.
to talk about, because the average age of menopause in the United States is 51. Okay. It's gone up about over the last 120 years, about 2 to 3 years, probably because of better health and nutrition, stuff like that.
Hmm.
The average age is 51. Now, there's certainly women who go through menopause at 35. We all know these people. We see them. I see them in my office. And again, I said some people go through it at 60. But what we do know is if a woman loses her ovarian function, either she has her ovaries taken out or she goes through premature menopause, and she does it, say, at 35 or 40, she's at significant increased risk of bone loss, heart disease, and dementia. We know that. And indeed, if this is Mayo Clinic data, it's solid data from Dr. Walter Rocca, who says that, who studied this, and that if you have your ovaries removed before age 45 and don't take estrogen therapy, your chance of getting dementia later on in life is threefold increased.
Right. Wow.
And that scares women. Understandably, it should scare women. So,
Hmm.
particularly when we have a youngster going through menopause, and this is what really got me mad about the WHI. I can tell you, I was very mad. I could use a bad word, but I won't. Anyway,
Well,
and the issue is that you have a young woman who's 35 years old and she goes through menopause. Okay. If you don't give her estrogen, you are increasing her risk of dementia threefold. You're increasing her risk of heart disease sevenfold. I mean, this is really significant stuff. Osteoporosis comparably. These are horrible things to happen to young women. And we know this. We knew this. Okay. And the WHI, the youngest woman enrolled in the WHI was age 50. They didn't look at any women with premature menopause. That wasn't part of the study. Okay. So the problem is that these young women, these kids, I mean, to me, a 36-year-old with menopause, a kid, and these kids were scared when they heard the WHI results. They stopped taking their estrogen too.
Mm.
And I was really mad because these kids are really vulnerable. And, they were scared. They heard you're going to get breast cancer. Oh, this is terrible. Well, you're not giving them an increased risk of breast cancer to a 35-year-old who gets her estrogen. This is not an appropriate thing to talk about. So anyway, fortunately, a few years later came out some recommendations saying, no, this does not apply to people who have premature ovarian failure or have their ovaries out as very young women.
Hmm.
The harm was done.
Right.
So, anyway, so if I have anybody out there listening, if you're really young, don't be scared to take an estrogen. Please go to your provider and get some estrogen, please. I'm presuming you can take it. So all of this stuff was going on. So there's a lot of politicization and a lot of young women who were pretty scared.
Right. Right. Yeah.
But
That's.
but the data that I have to go into, so for young women, I got great data saying you should take estrogen for Alzheimer's protection. What I can't tell you is I have fabulous data for Alzheimer's protection in older women, older women, like 50-year-olds, But basically, if you go through menopause at the average age, there's not a ton of data that says you're going to be at significantly reduced risk if you take estrogen. There is some data that shows it, there's some data that doesn't show it. So it's all over the place. So I don't have anywhere near as convincing data on that.
Hmm. But you have convincing data on women who are a bit older. Is that what you're saying?
Well, we do have convincing data. And this was actually from the WHI, they had some decent stuff there. And basically, if you look at the WHI, and they called it the WIM study, I love the names of these studies, WHI memory study. And they took women who were 65 and older. You had to be 65 to get enrolled in the WIM study. Okay, that's young too, but anyway, from my point of view. But anyway, they took 65-year-old plus up to 80, and they enrolled them in the study. And these were women who hadn't taken estrogen for years, okay, in general, and then started giving them full dose of estrogen. Well, that was bad.
Yes.
That increased the risk of dementia. Okay, not good to give people who have been off estrogen for a long period of time, giving them estrogen. We found that out. But what we feel that goes along with, and it's not necessarily Alzheimer's, it was probably what we call vascular dementia, sort of garden variety dementia that people get with hardening of the arteries, whatever you want to call it. Okay.
Hmm.
Which probably, and then we can get back to why did the WHI original study show no protection against heart disease? Okay, let's segue back. That
Yes.
indeed the average woman enrolled in the whole WHI was 63. Now, again, that's very young, but the 63 is not when they went through menopause. These ladies were in general 12, 13 years average postmenopausal. So what people discovered was if there's what we call a gap time, if there's some time between going through menopause or your ovaries coming out, whatever, and initiating hormonal therapy, okay, that if you got 10, 12, you got 12, 13 years of that or more, okay, some of these ladies were much older, 20% of the women enrolled in the WHI were between the ages of 70 and 79. Not my typical patient that I start prescribing hormone therapy.
No, not typical patient.
Rarely, very rarely. So the key thing is that if you take a look at these women for whom there is the significant gap time, if anything, it might have produced some heart disease rather than protecting against some heart disease.
Right. So there's that critical timing hypothesis that you do not want to
a gap time
lay too long, absolutely, before initiating treatment. Interesting. Yeah. And then also, I think they had shown some, which you were alluding to, some increased risk of stroke in those patients. Is that correct?
Yes, there's some increased risk in your older patients, particularly of stroke, and so that's why in general we don't push older women to initiate hormone therapy. Estrogen can increase risk of clotting in anybody, basically. The key thing is the baseline risk in young women is very small compared to somebody, and again, not the 70s old, but it's older, and there's a much higher chance of getting a clot in somebody who's 70 than somebody who's 35.
Right. Great. One thing you started to mention a little bit about is just contraindications to treatment. Can you tell us a little bit about that?
Sure. Well, one thing we are in general, we do mention gap time and contraindications. If somebody has gone a long period of time, somebody who comes in now and says, I'm 70, but I really missed not getting that estrogen and I want to get the estrogen now. Well, maybe that's not such a great idea. So that's one, and it's not an absolute, but it's a relative contraindication. Estrogen therapy is associated with an increased risk of blood clots. We know that. Now, we do know, and there are different ways to give estrogen. We do know that estrogen pills tend to have a slightly higher risk of getting clot than using a patch of estrogen or transdermal gel. Okay. Why that is easy to understand. That where are the clotting factors made? And I'm very guilty of pointing to my body, even on a video. So I'm pointing to my liver. And the key thing is that clotting factors are made in the liver. When you swallow a pill, goes down your esophagus, ends up getting to your liver pretty quickly, and so it can increase clotting factors. If you put a patch on, patches are going to get to your liver eventually, the estrogen is, but it's in a very dilute form. So estrogen patches, transdermal gels do not seem to increase that risk, okay, of getting clots, whereas the oral stuff does. And the other thing to remember is that birth control pills, because everybody's heard of birth control pills giving blood clots, the dose of estrogen in a birth control pill is way higher than your dose of estrogen in estrogen replacement therapy. We're giving very low doses in the estrogen replacement therapy. Birth control pills are much stronger, and so it's associated with a somewhat higher risk of clots. Now, of course, the women who take the birth control pills are in general much younger than women who take the estrogen replacement therapy, and age in and of itself is a risk factor for clotting. So you have to take all the stuff into account as far as who's a candidate and who's not a candidate. Okay. So contraindications clotting is, okay. And if somebody has a history of strokes, for example, which are related to arterial clotting, not always, but oftentimes, and also if you have venous history of thrombophlebitis, venous clotting, that's contraindication because of the clotting issues. Those are among your major contraindications, to taking estrogen therapy.
Yeah. And so some risk factors for folks would be people who smoke or people who have migraine with aura.
Migraine with aura, smoking. Somebody who, unfortunately, estrogen can stimulate the gallbladder and make it misbehave. So if somebody's got gallstones sitting around, well, if you want to aggravate them a little bit, you might aggravate them a little bit by taking some estrogen. Those are possibilities. And again, the transdermal seems to have less of an effect than the oral does. Okay. The other thing, if you're experiencing bleeding, okay, and you don't know why you're bleeding, but you're just bleeding, okay, you want to get your bleeding investigated before you initiate any estrogen therapy, okay, because there are sometimes people have tumors in the lining of the uterus where they shouldn't be taking estrogen. So any unexplained bleeding needs to be investigated, worked up before you think about taking any estrogenic substances. So those are important. And of course, the other major group of people people will talk about estrogen-dependent neoplasia, the people who have certain cancers which are quote unquote estrogen receptor positive. positive. Now, that doesn't mean the estrogen brought it about, but it does mean it can't stimulate it. So we discourage people who have active breast cancer with estrogen receptor positivity, particularly, to not take estrogen.
Yeah, I'm super glad that you brought that up because I know that that's a very interesting area. So I wanted to hear your take on how you approach patients who either have a history of breast cancer themselves or if they are at increased risk due to family history. How do you approach that?
Well, that's a very interesting question, Catherine. And you really have to address them two different ways, okay? Because family history certainly does increase your risk of getting breast cancer. There's no question about it. If somebody has a significant family history of breast cancer, it's not only your mom, but your aunt and your grandmother and stuff like that, I would strongly encourage those folks to talk to their GYN folks or internal medicine people about getting tested for genetic issues because there are certain genes that are associated with an increased risk of breast cancer. We know those now. And it's not just BRCA. There are many others out there, less common, but out there. However, just having a family history in and of itself, mom had breast cancer, and we'll talk when we find that one other step, that does increase your chances even without a genetic issue. Okay. Now, what's interesting, though, is if you look at the WHI data, this data they actually have, is that a family history does not act like, the analogy I use, is it like pouring gasoline on a fire? If somebody has a family history of breast cancer, are you pouring gasoline on a fire of getting breast cancer? The answer is no. Okay. I mean, yes, somebody who has a family history has a higher chance than somebody who doesn't have a family history, but adding estrogen will not blossom that risk out. Okay. So family history does not preclude use of estrogen. I tell people that it does not preclude use of estrogen. That's number one to remember. Personal history is a little bit different. So if you yourself have a history of breast cancer, most oncologists, not all, but most oncologists will not want you to be using estrogen therapy. Okay. There are some exceptions, and some oncologists will say in certain circumstances, yes, let's go ahead and give you some estrogen. But most oncologists don't favor estrogen in somebody with a personal history of breast cancer.
Great. Thank you for explaining the difference between those two. I think that's super important and very helpful, particularly for those women who do have the family history and are concerned, but are still going through the difficult symptoms of perimenopause and menopause. If you don't mind, just mention a little bit about topical vaginal estrogen because
Absolutely.
yeah,
it's really important because when we talk about the contraindications and stuff like that, we are really talking about systemic estrogen, and that means a pill, that means a patch, and there is actually one vaginal ring that has a high level of estrogen in it that we can use for systemic estrogen. More commonly used is a ring that just has a very low dose and is good for local therapy. Okay, so that's what we have. But local therapy for people who say my hot flashes are okay, they're there, but it doesn't bother me, whatever. But my vagina is killing me. I can't have sex. I'm really uncomfortable. I'm peeing all the time. All these things can be happening. Vaginal estrogen can be a godsend. It really can. Now, I do want to clarify that there are non-hormonal therapies for hot flashes, which we'll talk about in a bit, but that there's also non-hormonal vaginal therapy. So if somebody says, well, I can't use estrogen, and we'll talk about that in a minute, or I prefer not to use estrogen, there are over-the-counter remedies which work quite well for many people. Okay, but if the over-the-counter remedies flunk and they're not, helpful for you, vaginal estrogen is really quite safe. And the North American Menopause Society, now called the Menopause Society, and the American College of OBGYNs both have written position statements saying that vaginal estrogen is fine for use in a breast cancer survivor. The amount that gets absorbed is minuscule. That's quite true. And it's not going to affect her outcome. She's going to be fine. However, there are many oncologists who have a bird when the patient, wants to use vaginal estrogen. And obviously we talk with the oncologist as, the patient. And obviously many women, are too anxious to even think about it. So we have other options for them. We do. For making the vagina moist. But and the other problem that happens is when I have a patient in my breast cancer clinic and we talk about it and we're going to send, she's flunked a couple of, over-the-counter remedies, no hormones. And I say, let's try this. And I explained to her about the data that we have. And I explained to her about the American College's statement, Okay. And then what happens is she gets the package insert that comes with a tube of vaginal estrogens. And guess what happens? Her partner reads this package insert. She's at my lecture, so she knows what we're talking about. He'll read this thing, and the package insert for vaginal estrogens is exactly the same thing for systemic estrogens.
Right.
Same thing. So anyway, so the patient reads this, and the husband or the partner reads it and says, honey, it's not worth it to have sex to give you cancer. We're not going to do it. And so many partners will just, nope, we're not going to use these things. And I feel really badly for the patient. So actually right now, a number of organizations in the U.S., particularly a group called Let's Talk Menopause, the National Menopause Foundation, a bunch of other groups, are lobbying the government to say, will you please, and lobbying the FDA to say, please take out this stupid package insert, which has nothing to do with vaginal estrogens, but scares the hell out of people.
That's interesting. Okay, good to know.
That's going on.
I have just a question about that. So you mentioned the intravaginal ring that gives you systemic doses of hormone replacement, or consistent with oral or patch. Does that have first pass metabolism, or?
Nope, you avoid first pass metabolism. So basically, the ring, which is called a fem ring, because I can use a trade name. There's only one out there.
Yeah,
fem ring, and the fem ring basically counts as transdermal estrogen. Basically counts the same way. It does not increase the risk of gallbladder disease or clotting or anything like that.
Great. So actually, that's a perfect transition. So I'd love to hear your nuts and bolts on, oral, transdermal, intravaginal, the types of progesterone, and then some of the alternatives for progesterone when people cannot tolerate it.
Sure, absolutely. You're asking all the good questions there, Catherine. What can I do? Anyway, basically, and again, the other thing to remember is, let's get back to the fact that if you've had a hysterectomy, you don't need to worry about any of this progesterone nonsense. So we can leave those things to the side. So from a gynecologist's point of view, if everybody had a hysterectomy, life would be very easy. No, I'm not telling everybody to have a hysterectomy, but it is easy. So anyway, so if you take, and let's just talk about the different kinds of estrogen. The basic difference is between taking a pill and using what's called a transdermal, which includes like the fem ring from the vaginal route. And on the skin, you can use patches, you can use a gel, okay? And there actually is one product that's a spray, which is very rarely used. But it's still available, I'm pretty sure. But there was an episode of House where a kid, it's a terrible episode, where the kid was absorbing the mother's spray that was on her. It was a terrible episode. Kid got vaginal bleeding or something, awful things. But anyway, it's very rarely used. So again, the transdermal has the advantage of giving you no increased risk of clotting and probably less of a risk of stroke, although we don't have absolute data on it. So it's favorable. The other group of people that do better by using the transdermal are people who do get headaches, because estrogen withdrawal can lead to a headache. People get perimenopausal migraines and stuff. Excuse me. And those can be well treated by using estrogen. But people, if they have migraine with aura, they're not supposed to use the patch and stuff like that. Use the pill. They're not supposed to use pill, and they're probably not supposed to use patches either. But that's a whole nother question. But debatable. So there are certain things that are good and certain things that are bad. The pill, though, is quite much more commonly used than the transdermal. Transdermal estrogens tend to be a little more expensive. Some people have problems with transdermal because of their skin sensitivities. If you're one of those people who puts a Band-Aid on and gets a reaction to it, you may do better with a gel, and gel counts as transdermal. You may do better with a vaginal ring. I mean, there are plenty of other options out there. And we have basically graphs that show you the equivalent, what are your equivalent doses from a pill versus a patch versus the ring? What are you getting that's an equivalent level?
Yeah.
We can get you that information. That's no problem. So anyway, so basically, and the pill you take every day, there are some people who take a pill twice a day because they sort of chew up the estrogen and they need to take it on a more regular basis to get a decent sort of level, to put it that way. Those people might do better with transdermal, but that's a whole other story. So anyway, so there are the two basic ways to take your estrogens. Okay. Now we come to the wonderful world of progesterone. Okay. Because there are lots of different ways to take progesterone. And the main issue with progesterone, and I keep saying progesterone because that's the natural, that's what our ovaries make. That's what our uterus gets to sort of prepare to have a baby put in there. When we all know that it keeps the uterine lining in check in the person. But in post-menopausal women, for many, many years, natural progesterone is a little hard to synthesize. It's hard to make it. So the original progesterones that were made weren't progesterone. They were synthetic. They were progestins. They were not molecules that are found in nature, in other words. Okay. But they were cheap and easy to make, and and they protected the lining of the uterus, and that's great. And indeed, it was one of those that was studied in the Women's Health Initiative. We did not look at micronized natural progesterone. Okay. So anyway, but they do work. Some people do get side effects from progestins, okay? And some people even get some side effects from progesterone, the micronized natural progesterone. It's much less common. About 20% of women get a side effect from something called medroxyprogesterone acetate. About 10% get a side effect from something called norethindrone. Even about 5% do not like the micronized natural progesterone. So even there's some people there who flunk that. So your happiness on your medication is important. Do you get side effects? These are all variations of how we adjust the progestins. The other major issue with progestins, let me just grab a sip. This is a long discussion. But I can keep talking no matter what. So anyway, so the key thing is, we can keep talking. Anyway, so the thing about how do you take your progesterone? Okay. Varies. Okay. There are people who take progesterone or progestins every day, okay, to protect the lining of the uterus. They take a progestin every day. And there are also people who take progestins mimicking the hormones of the normal menstrual cycle. Now, I've got to get into some boring biochemistry, folks. I apologize, but you'll understand it much better when I explain it to you. Your ovaries make some estrogen every day. Okay. Now they make more at certain points of the cycle, less at other points of the cycle. But your ovaries only produce progestin in a significant level for about 12, 13 days of the month, of the menstrual cycle. Okay. So what we can do is we can play, I'm going to mimic your menstrual cycle. So I'm going to give you estrogen every day. And then for 12 or 13 days, I'm going to give you some progestin or progesterone. And what that does is stabilize the lining of the uterus. And then when the levels drop, when you stop taking it, okay, boom, you're good. And what'll happen is you'll get a period because it cleans everything out. Now, of course, when pregnancy happens, if the woman's pregnant, we don't want that happening here, that the estrogen, that the egg sort of makes some chemicals that keep the ovary working. So it keeps on making progestins and making progesterones, not progestins. But if you're not pregnant, out comes the lining of the uterus. Okay. Now, the one thing that women tend to be happy about with menopause, not all of them, stopping having the period. Some people like having a period, folks. I know you think I'm crazy. There are patients who like having a period. And you know what I say to my patients? If you want a period, as long as you got a uterus in there, I can give you a period. Don't worry. You like your period, I can take care of that. So that's something to keep in mind. But most people prefer not to. So many people prefer and they opt to take the progestins or progesterones every day rather than have a small dose as opposed to taking a big whack of it for 12 or 13 days each month. So that's the basics. Okay. Now, the next question, this is where it gets tricky, okay, is that we never used natural progesterone for many, many, many years because it was hard to synthesize. It was just a nuisance to synthesize it. And the synthetic ones were cheaper, easier to make. So everybody used them, okay. And they were fine. Unfortunately, again, a few percent of people just didn't really feel well on progestins. And again, about 20% of people flunk medroxyprogesterone acetate, et cetera.
And can you tell, sorry to interrupt you, but can you tell us when they don't feel well, what are the symptoms that they're noticing?
What do they complain about?
Yes.
Irritability, bitchiness, whatever, mood swings. That's what they complain about. A lot of them also complain about breast discomfort. Okay. And the other thing that people complain about is some spotting or staining. When you're taking the daily synthetic progestin, some people will get some spotting or staining that annoys the heck out of people. So that's important to know about. And again, we manipulate stuff and things like that. But the other thing that many of us have switched over to doing is using natural progesterone instead of using any of the synthetics. Okay. Natural progesterone is a little more expensive, although it's not absolutely outrageous. Okay. And natural progesterone has one really good property. It helps people sleep at night. It tends to be like a soporific there. Okay. So if I got somebody who comes in saying, I can't sleep at night. Yeah, the estrogen is going to help them a lot with that. But if I give them some natural progesterone with it, I'm doing a double good for them.
Right.
I'll get double goodness from taking the progesterone at night to help get some sleep. That's a good thing. So anyway.
So interesting. Sorry, just with the progesterone, because there are a couple of things that come up that are quite interesting for women who have an IUD in place, progesterone IUD, and also, as you mentioned, some women who don't have a uterus, they wouldn't require progesterone. In either of those patients, are you giving oral progesterone if they're experiencing a lot of difficulty with sleep?
Yes, I do. And sometimes give progesterone without any estrogen if I've got somebody who's really got sleep issues. I mean, obviously I'll have them worked up for sleep apnea and things like that. But if somebody's having a devil of a time sleeping, natural progesterone can be very helpful. There's only one problem with natural progesterone. I have to be fair and balanced here. That the key thing is to remember that natural micronized progesterone is mixed up in a peanut oil base.
Yes.
So I stop. Just I have to ask you a quick question. Are you allergic to peanuts? And people look at me like, what the hell is she talking about? And I say, well, this stuff happens to be dissolved in a peanut oil base. So I need to know if you're allergic to peanuts, which most people really aren't. Now, there is a form of micronized natural progesterone that is not dissolved in a peanut oil base, and we can get it both commercially and it can be available from your compounding pharmacies. So if you say, I really want to get natural micronized progesterone, but I do have a peanut allergy, don't despair. We can get it for you.
Oh, that's good to know.
The compounding guys can make it up. It's not a big deal. It's not a problem. You can get that. So that's easy enough to do. So anyway, so let's get back to another way to use progestins. Okay. Mm-hmm. There are these fabulous gadgets called Mirena IUDs or Kyleena. There are a whole bunch of different ones, which are coated with a synthetic progestin. And basically what it does is it keeps the lining of the uterus pretty flat so you don't get pregnant, but also it keeps the lining of the uterus fat and you don't get much bleeding either, which can be very nice. Mm-hmm. So a Mirena IUD, a micronized a synthetic progestin IUD coated with a synthetic progestin can be very effective for you as far as preventing pregnancy, which we'll talk about in a minute, and preventing bleeding. Okay. And it's a very nice complement to taking the systemic estrogen. It's a really good combination. Now, never say never in medicine. I learned that a long time ago. I've taken out a couple of IUDs, Mirena IUDs, for people who got symptoms from absorption of the synthetic progestin that was in their uterus. Now, it's a small amount of absorption, but it's not zero. And I call my patients like this, that fairy tale, The Princess and the Pea? The Prince Winifred, who could feel the pea under the 20 mattresses.
I used to love that story.
It's a good story. So basically, that my patients sometimes can find one molecule of progestin in their bodies that drives them crazy. So anyway, but in general, most people tolerate the Mirena IUD pretty well. It works well. It's now good for 8 years, and we're getting out the data on protection of the lining of the uterus for 8 years, so that'll be good. So it's a real good complement to systemic estrogen if you have a problem with the synthetic progestins. It is another very good option for you. Excellent. So those are the ways that we can give the progestins, and it works pretty well. The other really nice thing about having a progestin IUD in place is you're not going to get pregnant. And my personal best, remember, until you go that magic year without a period, okay, I cannot tell you you're not going to get pregnant, okay? Is it likely that somebody who's 49 is going to get pregnant? No, it's very unlikely, but it's not impossible. And my personal best is 47. I personally have delivered 3 47-year-old women who were not infertility patients. These were OOPS pregnancies.
Right.
So I have delivered 3 OOPS pregnancies.
That's great. Thank you for sharing that. And I think it's super important because absolutely, women, you would assume like my periods are irregular, or I'm not getting periods. It's just not possible.
Yep.
So that's good to know.
So the IUD can be good there. Now, I am going to backtrack a little bit while we're on that particular topic, if I may. Okay, because we've talked a lot about menopause. We haven't talked about some of the perimenopausal situations. How do we help those ladies? Now, I just sent an email to one of my patients who's out in California, so she likes to do it because of time differences, whatever. So anyway, and basically, we talked about her getting put in a Mirena IUD because she was having heavy bleeding as part of her perimenopausal transition. And I remember I told you we got to still worry about contraception for you. Just because you're 48 does not mean, it's
Right.
47, I guess she's actually. So anyway, so we talked about putting that IUD in. And the nice thing is it prevents pregnancies and it keeps her from doing crazy, funky bleeding. Okay. So it can be a very valuable adjunct in the perimenopause. It can be. But the other thing that I use a lot in perimenopause, taking into consideration pregnancy risks as well, low-dose birth control pills. Low-dose birth control pills can be fabulous for women in perimenopause. Why? Well, it gives them contraception. That's good. But the other thing is that what are we talking about with perimenopause? We've talked about these fluctuations, which are related to ovarian function. I give somebody a birth control pill. What am I doing to her ovaries? They're going night-night. They're out of it. Okay, they're asleep while she's taking the estrogen, the progestin, and the birth control pill. I am externally giving her estrogen and some progestin because that's what combination birth control pills are about. So I'm giving her a fixed level of estrogen, a fixed level of progestin, and sometimes she will feel so much better. She's getting some estrogen. I'm stopping her crazy bleeding. I'm stopping her crazy ovulation. And yeah, I'm externally controlling things, but it's fine. And many women are concerned about, is it, dangerous? If you're not a smoker, basically, and you're not at increased cardiovascular risk, you can take pills. I mean, as I standardize, somebody who eats sprouts and goes to the gym every day, you're a great candidate in general for control pills. You're not going to get into the cardiovascular disease, and it's quite good. There's only one other problem taking the birth control pill, as far as I'm concerned, during perimenopause, which is a non-problem. Taking the pill, you're not going to know when your ovaries poop out because the ovaries will be shut down by the birth control pill, so you're not getting any ovarian action, even though your ovaries could do something certainly early on, but we want to shut them up. You guys go to sleep. We don't want to hear from you. So what you have to do if somebody's on the birth control pill to see whether she's menopausal or not, you have to have her stop the birth control pill, wait a month or so, see does she get a period, does she not get a period? Then you can measure her hormones. If you measure her hormones much earlier than say a month before that, you're probably not going to get a true picture of what's going on with her ovaries.
Right. And just to clarify, so the hormones that we're going to be checking, we'll typically check FSH, estradiol, LH. Do you check progesterone level or testosterone on your patients?
Nope. And I don't even check an LH in general. An FSH and an estradiol are good enough for me.
Perfect.
They'll give me enough information.
Great. And then just a question for clarification. For women who are perimenopausal, do you ever do like a transdermal estrogen first instead of doing low-dose birth control, or do you just go to low-dose birth control?
I discuss it with my patient, and it's their decision, not mine. Okay. A problem is a lot of women in the perimenopause will be getting funky bleeding. They'll be getting wacky periods, heavy periods, and stuff like that. And if I'm just giving them estrogen without a progestin, I'm promoting growth of the lining of the uterus. And also that I'm on the days that her ovaries are making a lot of estrogen, I'm getting their estrogen and the additional stuff that I'm giving her. Okay. So she may get really sore breasts that day. Okay. The advantage the pill has, it shuts her ovaries down. Don't even think about it, as the kids say, don't even think about ovulating. You ain't going to do anything. And so that they will have very low level of spontaneous activity, and they're just getting external estrogen and progestin to keep them at a level. They won't have this raggedy, jaggedy up and down stuff that's probably what's driving them nuts from their perimenopausal symptoms.
And what's the difference in the serum level of estradiol when you're using a transdermal estrogen versus a low-dose birth control?
Well, that's an excellent question. You're too smart, Catherine. That's the problem.
Well, I learned from you.
No. The key thing is that birth control pills, you cannot measure the estrogen level because the birth control pills have a synthetic estrogen called ethinyl estradiol, which is not picked up in blood assay for regular old estradiol. So this is a trick a lot of times that happens. And I've had many mothers call me up who were hysterical. And I'll tell you the story why. So anyway, but the birth control pills do not get measured as far as a level, okay? But you got plenty of estrogen in there. And what will happen is your FSH is shut down, okay? In menopause, your FSH goes up, but if you're getting that birth control pill, you're down there. You're not getting any estrogen. You're not going to get an FSH elevation. So women will come back and my FSH is 2. My estradiol says I'm 2. What's going on? I'll say, well, you're taking the birth control pill. That's what's going on. Oh yeah. But what happens is that you can't measure the levels from the birth control pill. So that's why you have to be off of the birth control pill to see where are you really in the situation. And sometimes, because a lot of the kids take the birth control pills and their mothers know they're taking the pill, but they end up getting blood drawn for some silly reason in general, that they're getting their estradiol level. And go, my daughter's in menopause. She doesn't have any estrogen. I say, because she's on the pill. That's why.
Down.
Your daughter is not in menopause. She is taking birth control pills. Remember that. I mean, your daughter could be, but not now. So anyway, that's the key thing as far as measuring levels. While you're on the pill, and I tell my patients, they want to get their blood levels while they're on the pill. I said, you get your blood levels on the pill. I ain't going to tell you anything.
Right.
You tell me you're taking the birth control pill. Well, that's nice. I know that. So it really doesn't give you much information while you're on the pill. Now, the other thing, though, that we sort of skipped over because we left the hormone testosterone, I think, on the side there. We mentioned questions about testosterone. I don't routinely measure levels of testosterone just for a documentation on people. Because these are costly tests, by the way. So they're not like getting the blood sugar or something like that. They're pretty costly. And the problem is that, in general, testosterone is something, we know that people have it. If they're not showing any troubles related to it, like masculinization, a lady shows up like the bearded lady, I'm getting the testosterone on her. Absolutely. She has a ton of acne. Her hair's falling out. Signs of too much testosterone, I'm getting a testosterone level. Absolutely. And part of the problem, we think, that a lot of women start developing facial hair around the menopausal time. Their estrogen's going down, okay, but they're still making a fair amount of testosterone. So the ratio favors the testosterone more, so they're having more testosterone type appearances, including hair. Which is right there. So that's a problem for some people. So I sometimes will give them some estrogen to balance things out because they're all getting discombobulated because of the hair that's going on there. Right. So, but other than a problem, like if somebody's getting hair, I'll do a testosterone level. Somebody has significant issues with libido, I will get a testosterone level. So it's not that I'm opposed to getting a testosterone level. It's just there are certain things that it's indicated and certain things that it doesn't make much difference.
Yeah. It's so interesting with the patients that I've been seeing. I frequently hear concerns about low libido. So that's pretty common. And it's interesting because I'm finding a lot of low testosterone levels, which are, different from what we would typically expect. So I think it's a range of like 20 to 60 or 30 to 60 on the serum level of testosterone. Is that right?
Depends on which assay you're using,
Yeah, so it's interesting. And so that can help us segue into talking about sexual dysfunction and management with testosterone.
Sure. Well, again, in sexual dysfunction, we alluded to this a little bit beforehand, that certain vaginal dryness can make you uncomfortable and not want to have sex. And a story that I tell regularly, and many of my patients have been extremely kind to me over the last few weeks because they knew that I was a friend of Dr. Ruth Westheimer's and had worked with her in the past. And it was very kind of them to send condolences. And I will miss Dr. Ruth forever. She's a fabulous person, a real character, very smart and very funny. And I had the privilege of working with Dr. Ruth, and we did a tour around the country talking, as I was the gynecologist, she was the sexologist, sex therapist. And so the first time we did a talk together, and this is for lay people, not for docs, but for real people. And I got up and said, well, only a crazy person would want to have sex if it hurts. And Dr. Ruth looked at me and she said, Mary Jane, you shouldn't say crazy person. All 4-6 of her. And I said, but Dr. Ruth, would it be normal to want to have sex if it hurt? And she looked at me and says, Vel, no. And I looked at her, I said, Vel, it's like only a crazy person would want to have sex if it hurts. So my attitude, I want to fix their unhappy vaginas and get them totally comfortable. That's my first goal. However, as I alluded to earlier, there are a number of people who will come in and say, my vagina is absolutely great, it's perfect. And you can look at them, they have a perfect vagina, no dryness, and they still could care less about sex. Okay. Now, This is truly a can of worms to get into with a patient, okay? Which is why many doctors don't discuss it, because it's a can of worms to get into. And unfortunately, unfortunately, whatever, a lot of decreased libido is related to psychological issues, not hormonal issues,
Right.
okay? And Dr. Ruth would allude to that. Dr. Ruth would say, and I love doing Dr. Ruth's accent. So anyway, Dr. Ruth would say, the guy, he gets uphill, and he takes this blue pill, and he gets an erection that goes from the floor to the ceiling. Erection that goes from the floor to the ceiling. And but he hasn't taken out the garbage in a week. And God forbid there's a sporting event on, you're never seeing him. She said, does the wife want to say, come here, honey? No, not at all. And so you got to take in things like that into account, relationship issues. I mean, that's maybe a sort of crass way of talking about relationship issues. But there are many, and again, there are many, many things going on in a relationship that if you've been with somebody for a long time, if you're in the same marriage, you may be married for 20 years and stuff like that. You may be bored. You may be stressed, okay? And that just goes for hot flashes and anxiety too. For example, what a woman of 50 is not just a menopausal woman. She's a woman of 50, and she's maybe dealing with work issues where they may not be treating her real well from her work. Her partner may be dealing with work issues because they're not treating her or him real well with the work. And then a line that I use when I give talks to lay audiences and usually gets me a good laugh, and I'll say, and the kids maybe leaving home, and then I'll smile and say, even worse, coming back. And that usually gets me a laugh. You're dealing with kid issues. And then now these days, most people are dealing with parental issues, or occasionally even grandparental issues.
Mm-hmm.
So you have people who are, and again, the other line that gets a laugh is I say, and you're dealing with your aging mother, and even worse, your aging mother-in-law, because your husband ain't taking care of her. So that always gets a laugh too. So, you've got all these other issues that a woman is dealing with. And, she's got all this crap going on. Why would the hell would she want to have sex? It's just like, no, I can't deal with it. So, there are these other relationship issues, emotional issues, which are there. Boredom, you've been with the same person for 20 or 30 years, whatever. These boredom issues can be there. And then again, there's hormones too. And of the hormones which are out there, that the one that's really mostly implicated in libido is testosterone. And so testosterone has been now officially recommended by the North American Menopause Society, called the Menopause Society, the International Menopause Society, and they got data to show it, okay, that testosterone levels going down does lead to decreased libido for many people. However, there is no official form of testosterone in the United States available that's FDA approved for therapy for women. Right. Now, does that mean we can't do this? No. And I tell my patients, don't worry, this is not like Barry Bonds getting testosterone and hitting home runs and stuff. It's the same kind of testosterone, but we use much, much, much lower levels, okay, which work. And the problem is, though, again, without any commercially available form, we either have to go to a compounding pharmacy to get our testosterone. I happen to work with a couple which I think are pretty good. They take good care of my patients. Or we can use a tiny bit of the guy's stuff. That they have these testum packets and stuff like that, and you can use 1/10 of the dose the guys use, and it'll be okay. But it's a little hard to measure it out and stuff, so I tend to go with the compounded type stuff. And we can measure levels, and it is recommended that we do measure levels. You wait 3 months and stuff like that to see, are we giving you an adequate level? Now, of course, there are some signs that I want my patients to pay attention to. So certainly, if they wake up looking like Osama bin Laden, which they will not, they're going to notice a few stray facial hairs or something like that. But they start here, call me so I can get a level on you. Start noticing hair loss from their head. These are things that I want to know about so we can get a level early. In general, we'll wait like 3 months to check a level to see where they are. As far as absolute levels. But we measure levels. It is available. Is it reasonable? Yeah. Is there anything else that we use? Officially not, that the testosterone is the only officially recommended substance for lost libido in postmenopausal women. However, there are some drugs which are used for premenopausal women. There's the pill that people talk about, the pink Viagra, which is not a pink Viagra. D is what it's called, or Addy is the other name people call it. That can be used in postmenopausal women. It's been tested, let's put it this way. It's not officially FDA approved for postmenopausal women. And there is a shot of something called bremelanotide or Vyleesi, which also can be used, promoting the time of intercourse in advance of that. And there are studies in postmenopausal women. It's not officially approved for postmenopausal women. But we do have stuff in there. And again, though, I always encourage people to be creative and maybe liven up their relationships. And again, I will quote a friend of mine. I give full attribution again. This is from my friend Lauren Stryker. My friend Lauren Stryker, who does a lot of sex therapy type stuff. She says, you never ask your patient if she has a vibrator. You ask her which vibrator she has. That's Lauren.
Good call.
That's her quote. And so the key thing is, I always say, you got a vibrator? Oh no, well, let's get you a vibrator. It's good. So anyway, and vibrators, actually, there is documented literature showing that vibrators increase pelvic blood flow. And pelvic blood flow will lead to more moisture, and moisture is good because many women have dryness. So this is good all the way around.
Oh, that's good to know.
Yeah. And there are a couple of herbal products that people have talked about. Most of them don't have much data with them. There is one product that does have some data. I have to say, I do consult for the company because I've used their products, and they asked me if I consult because I use their products. There is a product called Restella, which is an interesting product. It consists of a couple of amino acids, which are the nitrogen base for the effect of this. And it has an herbal product, which is very popular in Europe, which is from the French maritime pine bark, which is called pycnogenol, which is very big in naturopathy world. And what this does, it's a nitric oxide synthase drug. So it basically increases the formation of nitric oxide, which is good because that dilates vessels. And supposedly, of course, when you have vessels dilated, you get more blood flow, you get more moisture. Well, all that's good. And supposedly, when you see this, your brain sees all this blood flow, it gets excited and says, oh, let's have sex because there's something going on. Sort of an easy way of understanding how it's supposed to work. The data from Europe, they have these incredible rates of success. We don't get the incredible rates of success they have in the European papers, but we certainly, in my cancer clinic, for example, when sometimes the use of some of these hormonal preparations is somewhat discouraged, that we use it because it's a non-hormonal product regularly.
Great. So much information. This is so awesome. I have one last question for you. And I honestly, I want to have you back so we can have more discussion. I have tons of things that I want to chat with you about. But I was thinking, what new advancements, because I know there are a couple, maybe this is a leading question, but what new advancements are you particularly excited about for treating women going through the menopausal transition?
Well, we do have some new advancements. And the most exciting thing out there are these what are called neurokinin 3 receptor and neurokinin 1 and 3 receptor antagonists. And this gets back to the all in your headline, that we have a pretty good amount of data now showing, and I think talking about the origin of this is very important, very cool. This was actually sort of discovered by a female neuropathologist. This was not from an OBGYN. Okay. And what do neuropathologists do for fun? They dissect brains. That's their idea of a good time. So anyway, she was dissecting the brains of some older women, and she kept noticing, woman after woman, significant growth or hypertrophy of the hypothalamus. And she was like, why is this happening? So she dissected it out and saw these interesting neurons. And she's part of the group that started coming up with what were these cells. And these were basically cells that had neurokinin B receptors on them. And there were these neuropeptides floating around in our brains called neurokinins. And there's neurokinin 1, neurokinin 3, etc. So anyway, these are neuropeptides. And what's really interesting is in the premenopausal woman who's got a lot of estrogen around, estrogen binds to this receptor up in the hypothalamus. Okay. So those nasty neurokinin molecules just sit there flapping around because the estrogen is occupying the receptor, so they can't go have a good time. What happens is when the estrogen levels go down, it's like neurokinin's gone wild. They can bind to the receptor because the estrogen isn't there blocking it, and they trigger heat. And they basically, the signals go from the receptor, which is now bound with the molecule, over to basically to the sleep center and to the thermoregulatory center. Okay. So you get hot, and you don't sleep. Well, that's really cool.
Makes sense.
folks started doing, 20, 25 years ago, when the people who really started into this business, they said, let's devise a molecule that's not estrogen, but does occupy the receptor. Okay. Can it be done? Yeah. Okay. And the first molecule is available now at your corner drugstore. You don't get it at the compounding pharmacy. And so basically, the neurokinin drugs, and the first one out there is a neurokinin 3 receptor antagonist. Okay. Very effective for hot flashes, is not estrogen. Okay. And of course, when I heard about these drugs, I was just ecstatic because I run a cancer clinic, and I just can't give estrogen to some of these people with estrogen receptor positive tumors. But I give it to these people. And I started talking to my patients about this 4 or 5 years ago. And they're like, every year, is it coming? And it's not here. Can I tell you it's coming? Yeah, it's here. Okay. And it's been used now over a year now. It's been available since spring of 23. And the molecules are good. They work. They work quickly, and they're very effective for hot flashes. Are they going to help your vagina? No. Okay. Are they going to help your aching joints? No. Okay. But are they great on hot flashes? Yeah. Okay. And they do help sleep secondarily to letting not flashing. Now, there is a newer one in process right now being tested, should be available probably this coming year, which actually has neurokinin 1 and 3 activity, and that hits the sleep. So that these drugs have been shown to increase not only hot flashes, improve hot flashes, but also improve your sleep.
Right.
So that's probably going to be crystal ball looking to 25 as far as that being available. But again, the other one works. The one currently available does help with sleep for many women because they're not flashing. And if they're not flashing, they can sleep, which is really a good thing. So this has been very, and we do have, and I want to tell people right now, we do have other medications out there which we have used for hot flashes in people who can't or don't want to take estrogen. We have SSRIs, SNRIs, which actually help with hot flashes. We have gabapentin, which helps with hot flashes. We have some herbal products which help. There's actually an herbal product just available now, just came out a couple of weeks ago, which actually mimics the NK3Rs.
Oh, interesting.
Very interesting. Yeah, it's called Thermella, and it's out there now. And it's, again, is there any head-to-head data? No, there isn't any head-to-head data. But does it help with hot flashes? Yeah, it does. And the mechanism seems to be very similar to the NK3s. So, I mean, there's cool stuff out there. So there's a lot of stuff. And the other nice thing about menopause right now is we can talk about it.
Yes.
Basically, for 20, 22 years, it was like, nobody's talking about it. And a couple of numbers that I'd like to share with our viewers, our listeners, that the Menopause Society has been around for 35 years or so. And we had 2,500 members of us nutty people out there being interested in menopause. And what happened over the last couple of years is a wake up on estrogen and a wake up on menopause, to be more general. And a couple of years ago, we went up to about 4,000 members. This year, we had 6,000 members.
Wow.
So
wonderful.
To me, that's wonderful. Yeah.
Absolutely.
Because people who are interested in this, people who are aware of it, we're going to get more training of our kiddies. I think that's really terrific. And I'm very excited about it.
Yes, I agree. And I really appreciate you for being such an advocate and, again, such a wonderful educator and taking it upon yourself to do some podcasts. That's how I found you originally. And
thank you for listening.
I just love listening. You teach so well. And this has been such a great conversation. I really appreciate your time. Thank you for speaking to me and to our listeners. And I can't wait till we get an opportunity to chat again.
That'll be great. Should we tell them about my website that's out there too?
Absolutely. How can people find you?
Easy. Go to madamovary.org. As I say to people, and just madamovary.org, and you can find such exciting things. What could be more exciting than a Dry Vagina podcast? I mean, really. I mean, nothing like
amazing.
That.
Absolutely.
We have Hot Flash podcasts. We have Dry Vagina podcasts. We have sex for people who can't take estrogen. We have all sorts of stuff there. So
wonderful.
Please, if you have some questions. I mean, there's other exciting. I got stuff on diabetes and pregnancy also on the site. So
we didn't talk about other women's health issues. A lot of interesting things as well.
There are many things in women's health. So everybody should go into that. So if I got any pre-meds listening or something like that, think about women's health. It's very good.
Absolutely. Well, again, thank you so much. And until next time.
Excellent. Thank you very much, Catherine. Greatly appreciated your invitation.
Bye.
Bye.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.